Well, good morning, good afternoon, and good evening, everyone, and welcome to the IFA's Global Café in Conversation with Experts series. As Bruna said, my name is Anna Sangster. I'm the Director of Policy and Innovation at the IFA, and I have the distinct pleasure of being your moderator for today's session with Dr. Leon Geffen. Dr. Geffen is a general practitioner based in Cape Town, South Africa. He is the director of the Sampson Institute for Aging Research and a fellow of the InterAI. I'm not sure if I'm saying that correctly, but it is a collaborative network of researchers and practitioners committed to improving care for persons who are disabled or medically complex. In 2017, Dr. Geffen was appointed to the World Health Organization's Clinical Consortium for Healthy Aging, and he also acts as an honorary lecturer in the Institute of Aging in Africa at the University of Cape Town. Leon has a particular interest in health systems research and is currently investigating novel ways of improving the assessment and management of people older than 60 presenting at primary care services. He has previously served as the medical director of Age Well, and in September 2022, he was named by WHO as one of the 50 leaders across the globe working to transform the world to be a better place to grow old. Dr. Geffen, thank you so much for joining us today. It is such a pleasure to have you. You have committed much of your career to advancing and supporting the health and well-being of older people. With that in mind, I thought it would be interesting to start our conversation today by learning a little bit about what spurred your interest in aging and what brought you to where you are today.
Thank you very much, Anna. It's a really great pleasure to be part of this, and thank you for inviting me to share with you some of my thoughts. What got me interested in aging? So as a young medical practitioner, being a general practitioner, I enjoyed working with complex medical problems, trying to solve complex medical problems. And older persons, by and large, had many complex medical problems. But then I started realizing that you couldn't just deal with an older person in the context of their direct health needs, in terms of what their comorbidities were, and you needed to actually look at the environment in which they were living. How could we actually start realizing and looking at making sure that people's function was being better looked after? Sorry, there's a neighbor's dog barking next door to me. Is that interfering a lot with the sound?
No, we can. Okay. I barely hear it on my end, at least.
Okay, good. Thank you. So I became interested in trying to understand how complexity of coexisting medical conditions interfaced with the environment in which people were living in terms of understanding the function. The thing that really led me into caring for older persons was, I became a general practitioner. I've been a GP now for well over 30 years, but I was in my late 20s practicing in my practice in Cape Town. And I had a patient with dementia who actually developed a delirium. And we're talking now over 30 years ago, and there was hardly anything in the literature. And I had not got any training as an undergrad medical student in caring for older people, and particularly about dementia. And I was completely at a loss to understand what was going on with this patient. And it was something that for me was a fascinating area to get involved in, and it spoke a lot to my desire to be a family doctor, understanding the holistic well-being of an older person, of people, and that's eventually what led me down that route. And then working in a low and middle income country, seeing the massive need for it, and certainly over the last 10 to 15 years, realizing how older people are very much the forgotten sector of healthcare services, social services, and particularly in low and middle income countries where most of the services are directed to, and rightfully so, to the younger population, child and maternal health being essential cornerstones for most of the health services. But that it's not a zero-sum game. It's not where we provide all sorts of services to young and older, young people, and no services to older people. And I think, unfortunately, in many countries, it is a zero-sum game where we're directing all our resources to younger people, to women, and we're not focusing anything on care of the older person. So it's about trying to to reframe that. And the Decade for Healthy Aging, I think, is essential to try and how do we, amongst the most deprived and lowest earning income, or the most needy groups of people, how do we start providing services? And then also, having had the pleasure and the ability to travel and seeing how services are rendered, and if I look at the models of care that we see in Ontario and North America and compare it to what's available in sub-Saharan Africa, it truly is worlds apart. And I think if you want to look at how the differential and equity, all the equity around healthcare is, and social services are, I think it's reflected very much in older persons and how services are rendered in, say, the high-income countries versus low-income countries. So those are the areas. That's what drove me or took me into the area.
Thanks very much, Leon. Your current research, as you said, is in health systems, and particularly improving assessment and management processes for older adults. I wonder if you could speak a little bit about what that actually means and what your day-to-day work might look like, and how the context in which you live has shaped that.
Yeah. So what we know, and certainly in South Africa, we have primary healthcare is, so we live in a sort of this blended service of private services and public services, where primary care theoretically is free at the point of access for anyone. And then one pays for secondary and tertiary services according to your means. That's in the public sector. And then the private sector. So what we see in South Africa is that about 50% of all the healthcare spend in the country is spent in the private sector, but that only services about 16 to 20% of the population. The other 50% is funded through the government, but goes to service about somewhere between 85 about 50 to more than 50, about 85% of the population. So a very small number of people are funded through the private sector, are self-funded, but they're spending an enormous amount of money. In the public sector, you've got an overwhelming need for good health care. And the HIV epidemic that came into South Africa in the late 90s, early noughties, led to a very large movement to build up primary healthcare services. So older persons have reported, and what we know from prior research, that older persons reported it's not difficult to access a facility. In other words, the structure's there, a doctor or a primary care nurse is there to be seen. However, when they get into a facility, they feel that they aren't being heard. There's a lot of the work that gets done is around process. Someone takes their blood pressure. They're in and out within 2 minutes. No one listens to them. No one asks them about all the major issues that are relevant to them. So as long as I can take your blood pressure or prick your finger and take your blood sugar, I, as a medical practitioner, have done my job. But what patients are reporting is, but I'm not being heard. We don't feel that the professionals who are treating us are necessarily competent to manage the problems. No one's talking to me about the pain. No one's asked me about whether I've had any falls. No one's asking me about loneliness. No one asks about incontinence. So knowing that, we asked ourselves, how can we actually upskill primary care practitioners? And when I talk about primary care practitioners, the vast majority of people working in primary care clinics in South Africa are professional nurses or registered nurses, and very few people would get to actually see a family physician in one of these clinics. So can we develop a system whereby we can have a relatively simple way of assessing someone, and when they arrive at a clinic, they can actually, in a very short space of time, be able to address most of the issues that are relevant to their needs. And that's where I've worked very closely with Interi, which is well established in Canada and North America, and Interi do an enormous amount of work out of the University of Waterloo. All the metrics around long-term care, services and home-based care services in Canada are fed into CIHI, which is the Canadian Institute for Health Informatics, as you may know, and they develop all these programs and are able to look at quality improvement in primary across the continuum of care. So that allowed me then to start asking the questions, well, how do we develop a model for assessing an older person in a primary care setting that can inform the practitioner to provide effective care to that person. So we developed an instrument which has now been scaled up and being used. It's still very much in its infancy, but it's now being used across a number of African countries as pilots. It's being used and modeled in North America, particularly in Canada, in Waterloo, in Ontario, which you probably know well, and in certain European countries as well. So that's where we've gone to try and say, can we assess someone effectively at a primary care level and not necessarily have high-skilled individuals like geriatricians to assess older persons.
Thanks, Leon. I wonder whether we can unpack that a little bit more and talk a little bit about kind of the assessment itself and what that looks like. You talked a little bit about kind of the need to upskill some of the kind of the healthcare professionals. And I know, in the last time we spoke, we talked also about kind of the importance of kind of person-centered care, patient-centered care. So I wonder kind of to what degree is that kind of incorporated within, the tool that you'd help develop, or what that kind of looks like in kind of a more practical way.
Yeah. So the tool that we've developed is something called the Checkup. It's an inter-eye instrument. It looks at a number of domains. So there's some basic demographics. Where does a person live? Who do they live with? What is their age? What is their gender, etc. It asks some questions around communication, ability to understand others, to be understood. Ask some questions around mood and cognition. It's very much focused on function in terms of your basic activities of daily living, and then also instrumental activities of daily living and the capacity to perform these instrumental activities of daily living. Then it looks at a number of health conditions such as pain and such as continence, falls, and then there's some symptom screeners that we have on there, for instance, around dyspnea or shortness of breath. We ask about some service utilization, having attended either a primary care clinic or a physician or an emergency unit. And then we ask about questions around sort of prevention and very much on psychosocial engagement and family stresses, and then individual stresses that someone may have experienced, and also something around financial trade-offs. So the whole assessment, which is a self-reported assessment, which can be administered either by someone who has a reasonable level of skill and say 12 years of basic education and is literate, so a family member to the older person who is a member of their family, or alternatively to be reported by the older person themselves, complete the questionnaire, and from that one can actually then make an assessment and talk to the person who's presenting and asking, well, what are the things that are most relevant to you? What are the things that you need the most? What is, you've reported pain, you've reported that you've had a few falls, you've reported that you're lonely. What is important to you, and understanding the person in a more holistic way.
Thanks, Leon. Kind of related to one of the questions that's come in, Shmuel, who attends every week, has once again added a great question here and asked a little bit about, the role of UN and WHO and other kind of intergovernmental agencies in supporting older people living in poor and low socioeconomic countries or low resource or constrained countries. And I'm just going to add to that a little bit that, listening to you speak, I can't help but think a little bit about kind of the ICOPE program coming out of WHO and wondering to what degree that's kind of related to the work you do, or, is that something that you see as kind of a contribution from these intergovernmental agencies in this space?
So, yeah, great question. So I think it's really important. So what we need to know is that both UN and WHO's global agencies help countries set agendas. They can't actually implement any programs on the ground. And the countries around that are represented within the UN and certainly within the WHO are all 200 odd countries of the globe. And it's really important to be able to provide countries with roadmaps and say, if this is where you are, what do you hope to achieve over the next 5, 10, 15, 20 years? I don't believe that any of the programs that are being implemented are going to affect change in a matter of 6 months to a year. And it's about, so the decade of healthy aging is really important because it actually shows that older persons at a global level are starting to become essential to be thought of, to be understood, to understand the fact that we can't marginalize older people. We can't be ageist in our worldview. And for very long, the world believed that older persons actually only happened, there were only older people in high-income countries. But if you look at what's happening with the demographics globally, probably by 2050, over 80% of older people are going to be living in low and middle income countries. Of the 2 billion people around the world by 2050, 1.6 billion are going to be living in low and middle income countries. So if we don't start looking at how we start providing services to them within the next 20 to 25 years, we are really going to be overwhelmed by needing to provide services. So yeah, it's essential that the global agenda is set. As to whether the UN and the WHO can actually directly impact on what a country does, I think that's a very long way away. I don't believe that's going to happen anytime soon, but it's about putting it onto the agenda and allowing countries to develop their roadmaps. As for the ICOPE, so ICOPE is the Integrated Care of Older Persons. And that talks to a number of areas. One is what we call intrinsic capacity. In other words, our physiological well-being, how are we able to, how our hearts are beating and how our kidneys are functioning, how our brains are functioning, and are we depressed and are we getting up and about? What's our vitality like? And then it looks at the environment as well and the integration, how your intrinsic capacity and your environment impact on your so-called functional ability. And that's what the ICOPE program's about. So a lot of the stuff that we've been doing and so we started at Interi working on these primary care instruments in about 2012. So it's been going on for about 11 years. So that predates quite a lot of what ICOPE is about, but the instruments all because the way Interi has always worked, it's about functional assessment, talks very much to the ICOPE methodology.
Thanks, Leon. I think, you touched on some challenges here too. I think there's the challenges of getting aging on the agenda. So I think there's those big challenges that we all deal with in the field of aging. But I was wondering if you can kind of speak to some of the unique challenges you see in those more kind of resource constrained settings and how that kind of exacerbates some of the global challenges we all see.
Yeah, I don't think we can discount in any way the impact of the environment on an individual, who we are, where we live, our gender, our education, all the social determinants of disease. Poor people have much worse health outcomes than high-income people. Women have far worse, have far longer lives lived with disability than men. Someone who is in pain on a daily basis because they cannot access simple analgesia. Someone who is visually impaired because there's no cataract service. So you take a country like Mozambique or most sub-Saharan African countries, where there may be 1 or 2 ophthalmologists in each country serving, tens of thousands of older persons. They're never going to get cataract operations. And I personally, if I took my spectacles off, if I took my glasses off now, I cannot see anything on the screen. I can't make out anyone's name on the screen. If I put them on, I can read everyone. And I think that's the experience of everyone sitting around this this discussion now who's wearing glasses. Now, the vast majority of people who are older are not going to be able to access the simplest and most basic of services, whether it's assistive devices like glasses, or a walking frame, or a walking stick, or some continence aid. The indignity of that, of having to not be able to go out of your house because you're embarrassed every time you go out and cough and sneeze, you dribble and wet yourself. You can't go out because you're living on the first floor of an apartment block and you have pain in your knees and you know that you just can't walk down the stairs. All of these things are incredibly disabling for individuals. So we have to understand that in the context of where we live and the environment. And the environment goes also towards the state's policy. What is the country's policy towards providing care and services to older persons? Are they just subsumed? In South Africa, as an example, there is no older persons policy as a standalone policy. Older persons policies fall under in the Department of Health in South Africa under the non-communicable diseases, chronic disease of lifestyle programs, as if getting older is a chronic disease of lifestyle. So yes, there's a department that is an older person the same as someone with diabetes and hypertension and COPD? But well, we've got to put them somewhere, so we'll put them into that sort of. And I think the messaging around that, it's not fair and it's not nice to say, well, you're an older person, well, you've got a chronic disease of lifestyle.
Yeah, absolutely, Leon. I think, again, somewhat related, but maybe a bit of a departure from kind of our current conversation is, again, I think you were talking a little bit about kind of conducive policy and the importance of kind of policies as well. What does kind of, policies around long-term care look like in South Africa, but more broadly, sub-Saharan Africa, and how are kind of, again, I think we all see challenges in long-term care. What are some of the unique challenges that you face?
So, thank you. I mean, that's really, so long-term care is who does provide that service to an older person as the ability to do the things, whether it's your shopping, whether it's your transport, locomotion, whatever it is, your cooking, as those abilities start to decline. And certainly in South Africa, so the government in South Africa, as we have a policy called, or government, an act of parliament called the Older Persons Act, and that was enacted in 2006, and all the regulations that came out of that was in 2010, and it talks very much to providing and supporting people living in communities. So that's what the state framework says. However, the implementation, being able to provide that to people living in communities, is incredibly small. So what we see in South Africa is that there isn't an old age pension. So anyone over the age of 60, based on a means test, is entitled to an old age pension. And in fact, an old age pension in South Africa is in the order of 2,100 Rand, which is in the order of just under 200 Canadian dollars a month, which is used by an older person to actually fund not only that person, but because we have many people living in skip generation families where grannies in particular, grandmothers, are looking after their grandchildren or other members within the family. That money is used to be spent on not only person's medication, if they can't access it at a primary care clinic, but also food for the whole household, school shoes for the children, getting to and from school. So that's what we see what's happening with the older persons grant. Now, South Africa, as a low and middle income country, as a middle income country, and certainly an income country in sub-Saharan Africa, it's very fortunate that we can provide that sort of pension to older persons. But the vast majority of older persons in sub-Saharan Africa have no access to social grants. And only now are we starting to see a few countries starting to implement social grants, but they're still incredibly low value in terms of what people are getting.
Thanks so much, Leon. I'm going to turn to Dominic here. He's got a great question about kind of leadership in long-term care. So Dominic, would you like to come forward and ask your question?
Thank you very much. Yeah, I was attracted to the title of the presentation today. I used to work I worked in 2 nursing homes many years ago. And when I think about leadership in long-term care, we have nonprofits, we have for-profits. What do you notice, Dr. Leon, in terms of the attitudes, the ways of thinking and so on that you come across in terms of the leadership in long-term care, and how might that need to change? What have been the sort of some of the problems you've noticed in terms of how leadership functions, and what are maybe some solutions?
Yeah, I think you're going to be pushing a very sensitive button over there, because I think the COVID pandemic showed us what happened in terms of the outcomes of for-profits versus not-for-profits. First of all, we know that the not-for-profits performed much better than the for-profits when it came to providing care and services to older persons during the COVID pandemic, particularly in long-term care facilities, nursing homes, where we saw. I personally, I think that we should be supporting the not-for-profit sector. I think what's happened in terms of service delivery is that the not-for-profits are scrambling around to try, and in South Africa in particular, I can speak to the model in South Africa. Most of the not-for-profits are actually community-based organizations or mission-driven organizations designed to provide service and care to older persons. And it means that the state then abrogates its responsibility to the not-for-profits, who have to scramble around to keep running and to get money. And the people that their constituents are very, very poor low-income earners and can't afford the services. Whereas the for-profits are providing services which, at the end of the day, is designed to provide a return to investors. And there's very little commitment to quality improvement, quality indicators, etc., and no one benchmarks them. So I think that I'm not particular. I love the Canadian model. We shouldn't be profiting out of someone's misfortune and ill health. Having said that, I have been a GP in the private sector in South Africa, but I think when it comes to providing services, the state needs to provide the services and actually be responsible for care of older persons. Older persons, by and large, have contributed to the society being what it is today. They've paid taxes throughout their lives. They've either worked or and they've contributed to society. And if we don't actually look after our older people, we are denying their role and their, everything that's come before them. And I think it's a sad indictment of society if we can't provide care to older people who require it.
Thanks very much, Leon. Interesting question here from Dr. Asha, who's talking a little bit about kind of a shifting state of play, and kind of as urbanization happens, often those kind of, I think, cultural precedents that we rely on, whether it's kind of caregiving from families and things like that, often can't be relied on to the same degree. So I'd love to kind of touch on that and welcome Dr. Asha to come forward with her question.
Thank you. It was a pleasure listening to Dr. Leon. Only thing is, my concern is, there are the traditional family givers we had in India. They are breaking. Governments, they try to do, but it does not reach people. So how can the governments and society both be pressurized to take care of their elder population, which is going to increase by leaps and bounds? And infrastructure, service providers, they are minimum. And as sir said, quality does not exist, even if they are ready to pay.
Right. So I think that is core to what this discussion ultimately is about. It's about who provides long-term care services and who funds long-term care services and who does the long-term care service. Now, traditionally, we all pay some sort of homage to this idea and this notion that families take care of one another. And well, if we look at the models in poorer communities, well, the family cares for them, or traditional communities. And I think it's an old hackneyed view of the world, because I think it's more to do with class rather than who the community is. That as families become more upwardly mobile and socioeconomically advancing, they start outsourcing the care of the older person to either a long-term care facility, and they will send mom or dad or husband or wife into a care home because someone else can look after them, or they start being able to afford care services, so they get home-based care services. And if, for instance, we have models that aren't like the Canadian model, where the state will provide the home-based care facilities, people will buy them in South Africa or maybe in India, where you can afford to employ someone to do it. In the vast majority of cases, the person who's providing the long-term care service is actually a family member, and most often is a female member of that family, whether it's a daughter-in-law, a daughter, a niece, or a wife. It's seldom that you find men in that position. And people who are providing that, and the women who are providing the service are by and large not paid for the service that they're rendering. So it becomes a form of almost indentured labor. And what happens is that those women who are providing that service are unable to go out and upskill themselves. They can't go and get a better education. They can't become more economically active. So it ends up subjugating that person to providing care for many years and further entrenching that individual's poverty. And I think there is a very strong gender aspect to that, which I think the state, once again, also needs to recognize and think about how do they remunerate the caregiver. And then the other essential thing is, how do we motivate the state, the country, the government to start providing those services? And I would like to believe that that's one of the things that comes out of the decade of healthy aging, where the WHO and the United Nations say, we need to start considering, what does long-term care services look like? How do we fund it? Who's going to fund it? Is it self-funded? Then you ask someone to self-fund it, where you're asking people to invest in a service that they may or may need going forward, maybe 30, 40 years. If you turn around to someone who's in the early 30s and say to them, put away a certain amount of money into an insurance policy that if and when you get to the age of 75 or 80 or 85, you're going to need some sort of long-term care, people are going to turn around and say, well, I've got to put money into my home insurance and my paying for my kids' education, and actually, I've just got to put food on the table and I've got to pay my mortgage. So why should I put the money into that? It's something that's so far down the line, I don't even want to consider it. So to ask people to self-fund it, by and large, those systems haven't worked. And so I think it does, once again, become part of the state's responsibility in terms of finding models of financing it and funding those sort of services. And hopefully the UN Decade of Healthy Aging and the WHO working in conjunction with it sets up the models by which countries can have the framework to look at funding models for long-term care. And the reality is, if we don't start doing it now, by 2050, we're going to be completely overwhelmed by it.
I do agree with you, sir. And definitely, we need to develop caregivers, care homes, help age centers, and also geriatric centers. Thank you very much for your inputs. Thank you.
Thanks very much, Asha. Dovetailing off of that a little bit, Leon, I think we've all talked about the challenges of population aging and just kind of the strain that has put on systems. I look at even, for myself, my grandmother's, dealing with a fairly advanced dementia at the moment. And we've been on, I think, a list for long-term care at 2 years at this point, and they're probably looking at another 2 years before she can really get into a facility. Now we have the luxury of being able to kind of have her in a private care facility right now, but that's not an option for a lot of people, and that's, I think, going to continue to be a challenge, that even in countries where we have kind of more state-sponsored long-term care or kind of assistance in that way, there's this imbalance on the number of people that need care and the actual infrastructure we have. To what degree is that a problem in your context, and to a certain extent, what degree is that exacerbated due to some of the constraints?
So once again, I can speak to South Africa, and probably most people around are very familiar with South Africa's racial history in terms of apartheid. Nelson Mandela's a name that's probably very familiar to most people. And what we need to know is that South Africa is a country of vast inequality, and race by and large depicts class. So Black people in South Africa are much worse off than white people because of apartheid. And apartheid came to an end in 1994. It's just almost 30 years ago. However, the inequity and inequality that exists from apartheid is going to carry through for many generations. And just in South Africa, as an example, there are no long-term care facilities. And in a racially segregated society where we still have, by and large, a lot of racial segregation, not de jure, but de facto, people have lived for generations in certain areas. There are no new old age homes, so to speak, being built in any of the so-called former Black communities in South Africa, or in Cape Town, where I'm living in particular, because the government policy is we want to support people in their communities. And to a large degree, it's allowed government not to build the facilities by saying we actually are funding people in the community. So they're neither funding people in the communities, nor are they building the old age homes. So older persons are not getting the services either in the communities or in facilities that should be providing the care to them. And if we go further north, if we go to Zimbabwe, a care home is not anything more than a facility that will house something between 60 and 80 people. And honestly, there will be possibly the most rudimentary meal served on for people who can't live in the community because they've got dementia, they may be a risk to themselves, and they're lucky if they have their bums wiped. I hope I'm allowed to say something like that. I've said it anyway. But the services that are rendered are nothing more than that. And that's the model of care that's across broad sectors of broad swathes of the continent of Africa. Maybe Dr. Asha can also mention about maybe, I'd love to hear what her experience of India is, but certainly having spoken to colleagues of mine from India, it's a similar experience there, where you're going to have, tens and tens of millions of people over the age of 60 or 70 or 80 requiring care. How many care homes have been built in India? And what's the quality of care there?
India, it is yet to develop facilities of caregiving. Yes, Tata has started an institute. They are training caregivers. Mr. Tata has started a startup under a young boy. HelpAge India is having some institute, but still it is not reached to many. It is reached only to very few who have got resources, but others, they are just left to die wherever they can, peacefully.
Thanks, Dr. Asha.
And that's one of the things that really reflects the difference between a high-income country and a middle and low-income country. I come over to Toronto, and I'm absolutely astounded at the quality of service and the number of facilities that are available. I look at a community like the Schlegel Villages or Baycrest in Toronto. There's nothing like that in low and middle income countries.
Before we kind of move on, kind of shift topics a little bit, I want to come to Dominic's comment about, you've spoken a little bit about kind of how race has played a role in some of the access to services, certainly in South Africa. And I think that's definitely not a unique problem. So I'm wondering, and there's the question here about data. So I'd love Dominic to come forward and ask his question, because I think it's a really interesting one and speaks to kind of some of the issues in lack of data collection. Dominic?
Thank you. In our health system generally here in Canada, I'm in Nova Scotia, there was a person talking on the radio about Black men in particular and their experiences and their distrust of the medical system. And this got me thinking about how racism, long-term care sort of reflects the broader society that it exists in. Are you aware of any studies, Dr. Geffen, that explain, just how big of a problem racism is, well, in your country, I guess, but in other countries too, when we're talking about long-term care?
Once again, what did we learn from the COVID pandemic? That older Black people, irrespective of class, did much worse than older white people. Now, why is that? We haven't got the answers. Well, and that's really, really important to know. So it is about the data. And there's a paucity of data in low and middle income countries around aged. How do we care for older persons? And whether it's just simple counting of numbers, how many people are actually over the age of 60? How many people over the age of 60 have got cognitive impairment? How many people over the age of 60 have got access to healthcare? How many of them have received COVID vaccines? So race plays is a very, very, certainly in South Africa, it's a major, major indicator of health inequality. And certainly from what we saw from the COVID pandemic in North America too. So we have, and why? Why is a Black person different to a white person according to all these health parameters? It can't just be the color of your skin. It has to be to do with the environment in which people are being brought up and in which people are being looked after and the services that are being rendered to people. And I think it has to, we have to be completely open and transparent about it. And we need to actually ask the questions, and we need to hold people to account as to why these differences exist in the global north.
Thanks very much, Leon. Shifting a little bit to kind of, I think, the paradigm shift that needs to happen, or the shift in thinking that needs to happen. I want to come to Joanne, Joanne's comments. Joanne, would you like to come forward and ask Dr. Geffen your question? Joanne?
Sorry, I was looking for the mute.
No problem.
I'm just wondering about promoting the value of individuals more. There's so many ideas. I think we are valuing seniors and older adults more, but the focus has been on their medical and physical care and segregating them instead of valuing what they still have to give and what they can contribute to society and our economy. And I think, even something as simple as having field trips from elementary and even high school and even med school or anywhere to a long-term care facility or to anywhere where seniors are, and have them question older adults about the effects of aging on the physical body, what sports they're able to do or what they did, ask them about history, so the changes of things through their lifetime, but using them as an educational resource. And that's just one example of finding a way to give older adults value instead of, sort of paternalizing and taking care of them and just looking at their physical needs, looking at how they can give back to society, looking at how we can keep them integrated. I think with more value and more independence. Sorry, I'm better with my writing than I am with the words. That's okay, it's sort of in a chat section.
I think we've got a great kind of idea of where you're focusing there, and I know that Dr. Geffen's had many opinions about this, so I'll hand things over to you, Leon.
Jan, thanks. I think that's it's also an essential element that you raised. First of all, the intergenerational aspect of how do we deal with intergenerational issues and letting younger people understand the lives of older people. But then also importantly, that, and I think this is very much part of the decade of healthy aging, one of the pillars and the models is the role that older people play in society. Being old doesn't mean you no longer have a role to play in education, training, developing yourself. developing new skills, contributing to society. And I think we've forgotten to ask older people how they wish to contribute and what contributions they wish to make. And I think it starts in the home. If there's an older person in the home, everyone's very engaged around younger people. What are they doing, and what's the latest music, and what's the latest fashion, and what you're seeing on TikTok and all the rest. And no one actually asks the person who's 70 or 80 or however old they are, or, what was your experience, or what have you done? Let's hear a little bit about you. And I'll go back to Anna's original question. What got me interested in aging was actually hearing stories of people who the older person's story, the role that they'd played, or just very simple stories about their lives. I think of my own grandmother who died at the age of 94. She'd lived through the Second World War. She was an independent woman who ran her own business throughout the 20th. So she was a walking history of the 20th century that I learned from. And I think we need to bring older people into that conversation in our own homes, not just when you're having a dinner party. Well, there's granny or grandpa, and they're just sitting in the corner and no one speaks to them. Well, let's engage them. Let's ask them, what's their attitude? What are they doing? So it's the contribution that older people have made to society, are making currently, and can continue to make. I think one of the very, very important things to start talking about is we have this concept that older people are a drain on resources, but we don't reframe that. We need to reframe that and say the role that older people bring in the economic activity of the society around it, whether they are actually giving employment to someone who is going to provide care to them, or whether they are spending their money on a cruise going off to Miami, to the Bahamas, or wherever they are. The amount of money that older people put into the economy and contribute to society is enormous. And therefore, we need to start valuing them. And how do we affect change? I think older people need to become advocates for change. It's not going to be the young people. A 20, 30-year-old person is not going to advocate for the change for the older person. Older people have massive economic might. They are, as the total number of older people around the world grow, have a role to play in choosing the governments who are going to be governing them. So you need to ask those people who do you want to vote for? Do you want to vote for someone who's going to promote your cause, or do you want to vote for someone who's actually going to deny you the rights as an older person?
Thanks so much, Leon. I want to come back just kind of where the conversation's taken us to a comment from Eileen, which is really kind of touching on, I think, some of that advocacy and empowerment. And kind of, I think there's some skill that comes with being able to kind of advocate for yourself, and certainly in the context of kind of engaging with health professionals. So Eileen, would you like to come forward and ask your question?
Yeah, thank you very much. Dr. Leon, it's absolutely very enlightening and encouraging and uplifting to hear your advocacy and encouragement role, especially in your last comment, because I'm involved in other groups which says retired workers are not retired voters. So, and we're trying to get the voice of older people at tables where decisions are made about us without us. But the other thing we're finding in a national policy in Ireland, and I'm just wondering on your comments on this, is they're trying to shift the management of your own health to the individual. Now that requires us to train, but it also instills in how to manage and interact with the professionals, as well as the professionals trying to interact with us, assuming we have the capability to do so, and adjusting for that. Have you considered anything in that line, a joint training sessions of what you expect from us and what we expect from you in a collaborative way?
First of all, Eileen, I love the flower behind your head. It's a beautiful flower behind your head.
It's a sunflower.
I love that slogan. I've written it down: retired workers are not retired voters. I think I have to use that. If you don't mind, I am going to use that. So it comes to this whole, and also interesting element of, it's almost a neoliberal view we have of the world. Well, you're old and frail and decrepit because of how you lived your life. You smoked and you drank and you're overweight, and everyone says, you as an older person, well, all of these things are, you could have had an impact on how you're living your life now. And for the vast majority of people in the world, it completely doesn't take into context the actual context in which they, in consideration, the context in which they've lived. The fact that I'm living in poverty, I can only afford the cheapest of food, which is calorie rich with low protein, and therefore I am at risk of getting osteoporosis as I get older. I am at risk of getting diabetes. I'm living in abject, dire circumstances, and I do drink alcohol. And I think we have to once again move away from this whole neoliberal concept of well, the individual takes destiny of their own future. I think this, once again, it shifts all responsibility away from the state. And I'm not advocating a communist approach to the world. I'm advocating a role where the state actually needs to take responsibility for its citizens. And I really, truly believe that the state needs to take responsibility for the citizens that has put it there. So yes, retired workers are not retired voters. And I think the retired workers need to vote into power the people who can make a difference to their lives.
Yeah, absolutely. Thanks, Dr. Geffen, and thanks, Eileen, for your comment. I'm gonna prod a little bit more on this, because I think I'd love you to touch a little bit, Leon, on kind of the training aspect, and whether you think what opportunities and what's the importance of kind of upskilling some of those advocacy skills, and kind of I think probably for all generations, but being able to kind of communicate more effectively with healthcare professionals about our needs and our priorities. What's kind of some of your insight? Are there trainings available? Do you think that's an area that needs more attention and work?
Okay, so once again, some of the work that we have done through SciFar is looking at training. So first of all, in terms of healthcare professionals, doctors, and I'm pleased to see that Sebastiana Kalula, my colleague from Cape Town, is on the line as well and part of this discussion. She was the emeritus professor of geriatrics at UCT at the University of Cape Town. Undergraduate training in geriatrics is, I think, maybe 4 to 6 lectures in total over a 5 to 6 year medical school training program. So there's hardly any undergrad training in geriatrics. I know I used to lecture to undergrads. Those came to an end a while ago. At nursing school, there's no specific training in care of the older person. And when we ask the nursing schools what's their training, they say, well, our nurses get trained in neurology, where they will see someone with stroke. They will be trained in orthopedics, where they will see someone who's older, who's fallen and fractured a femur. They will be trained in neurology, therefore they will have seen someone who's incontinent. But no one packages it all together. The same thing happens in physiotherapy and in occupational therapy. And then when we start talking about carer training, caregiver training, it's a highly varied field that there's mandated legislation around what a caregiver has to be registered with the registering authority, but it's not implemented in any way. A lot of the caregivers are trained over 5 to 7 days, sort of Red Cross ambulance or Red Cross first aid course. There's no skills-based training. There's very little in the way of what it is, of what should be, certainly in South Africa. So there's very little in the way of skills-based training, and lots of people are getting the skills so-called on-the-job training. So that's a major problem. And we go to the medical school authority or the trainers, they say, where in our curriculum are we going to fit it in? We've got no time. We've got to compete with pediatrics, and we've got to compete with cardiology and neurology and orthopedics, etc. So where are we going to put it into our curriculum?
Thanks very much, Leon. No easy answers here, I think. One question, actually, I think we're quickly approaching the hour, so I'm going to leave you, Leon, and to generate some kind of key takeaways. And I'm going to ask my colleagues, Bruna and Luana, to share our speaker for next week, who is Dr. Michelle Halperin-Benzie. And she's going to be focusing on accelerating the usage of digital services among older adults 65 and plus through industry engagement. So it'll be a really interesting discussion, and hope that you can all join us next week for that conversation with Dr. Michelle. So Dr. Geffen, with that, I'd love to kind of flip things back to you and hear kind of some of your key takeaways for today. What do you want to leave us with?
I think a few things. One is improving assessment of older persons at a primary care level can make a significant difference. It's about engaging the older person about what their needs and what their desires are. It's not just looking at the biological need of an older person, it's about looking at the psychosocial life and the environment in which they live. I think we need to improve long-term care services by upskilling our workforce, by improving access to long-term care services, by remuneration of people who are working in the field, making it a desirable area to work in. It's not a dead-end job for vast majority of people. And I think coming to the point that Eileen raised, retired workers are not retired voters, and that's to say that older persons must become advocates for their own change, because I don't think anyone else is going to do it for them.
I think Eileen's left us with quite the soundbite today. I think I'm going to steal it as well. So again, on behalf of everyone, thank you so much for joining us, Dr. Geffen. It's been a real pleasure. And thank you as always to our audience who continues to be engaged and makes this such a fun way to start my Friday. So thank you, everybody, and Dr. Geffen. It was an absolute pleasure. So enjoy your weekend, everyone, and we look forward to seeing you next week. Thank you.
Thank you very much. Bye-bye.